Well, good morning, good afternoon, wherever you happen to be logged in from. I am Dr. Dan Mingle. Welcome to today's webinar. There is so much going on right now. It is holiday season. Happy holidays, everyone. I don't have time for this, so someone remind me when it's Christmas Eve. It is our crescendo season in PQRS, so it's going to get busier for us every day until March 31st, the final submission deadline. Don't forget to engage for your 2016 submission. And MIPS macro final rule is out, as you know, and that's why you're here. So we are retooling all of our webinars, and this is the second in the series, or third in the series, excuse me, I'm getting behind. We presented on a general overview. We presented on alternative payment models last time. This is on quality, and coming up is the rest of the performance categories. We'll do cost, advancing care information, and clinical practice improvement activities in separate sessions. So welcome again. Oh, and it's snowing here in Maine. So again, lots of things going on. Let's see if I can advance these slides. There we go. So today's agenda: a couple words about PQRS macro and a wildcard administration, what to expect in the new administration, a brief review of the quality payment program, then we'll dig into the second pathway, that's the merit-based incentive payment system, and specifically today the quality performance category, and talk about opportunity, risk, and strategy overall, how you succeed in MIPS, particularly with a focus on the quality category. So those notes, the old programs have one last submission period, so don't think it's over. Don't relax yet. You can still lose up to 6% of your Medicare allowable charges if you don't submit PQRS for 2016. Those submissions, of course, are due, depending on your mechanism, sometime between February 28th and March 31st. Getting back to MACRA, Medicaid and hospital meaningful use are unchanged by MACRA. So as you move ahead, if you're participating in either of those programs, MACRA doesn't really change that, except that your performance under Medicare meaningful use no longer qualifies you in the Medicare and hospital meaningful use category. Also, thinking about that wildcard administration, you know, there's lots of promises of gutting ACA, of rescinding it. It remains to be seen exactly what's going to happen there, but MACRA is not ACA, so the Affordable Care Act. A lot of what we did in PQRS in years past had to do with ACA, but MACRA completely rewrote things. It's a whole new program, and the requirements under MACRA have nothing to do with ACA. There's reason to think that that Congress is fully behind it. You know, remember that the vote in the Senate was 98-2 to pass MACRA. It is bipartisan. I do think that we can expect maybe a faster rate of evolution and some more year-to-year adjustments to match the new administration style and predilections, but MACRA you can expect to remain intact overall as a concept through its 5-year life, and something to replace it when it's tested out fully in its 5-year life. And I say that 5-year life not to say that it expires in 5 years, but it was built as a 5-year transition program that's transitioning it to its full maturity in 5 years. So I really don't expect any major changes until Medicare and Congress test out its results over the course of those ratcheting increases. Now, you're also aware that the 2017 has been declared a transition year with fairly easy ways to avoid the penalty, but again, don't rest on your laurels there. Make sure your submission is rock solid. There's still lots of ways to technically fail. And even though it looks easy, you can easily lose your balance and fail on this. So get professional help. Engage helped to manage the CMS processing errors. You know, I think we've been understating that in past years. This was a horrible year for Medicare processing errors. Oh, excuse me, that should, there, bring that back into control. Medicare processing errors, in our experience, about 99 out of every 100 judgments by Medicare that you were going to be penalized were wrong. Were just based on their mal application of their own algorithms. And they fixed most everything. If yours hasn't been fixed yet, get help. Call us. We'll help with that. I wouldn't even take the informal review deadline seriously. If it's Medicare's mistake, we should be insisting on them fixing those problems right along. So keep pushing it. And also put your infrastructure in place for 2018. It's not too early now to start making sure you're intact, because this is going to be a more demanding, more competitive program as it moves out. And your access to data, your automated connections, your optimizing your performance, all those are going to be very important, as we'll get to. So again, MACRA, this is all about MACRA, the act that was signed into law in April of 2015, and you know the rest. I'm not going to bore you with all of this. And it's taking those 4 programs on the left that we've grown to know and love, and combines them all into one coordinated program without all the contradictions and overlap and redundancy of the old. And Medicare's reconfigured it, calling it now the Quality Payment Program, acronym QPP, with a first pathway, and this is Medicare's lexicon, or it's the alternative payment models as the first pathway, and the merit-based incentive payment system as the second. Now, if there's anything that's going to be modified by the current administration, it's probably the first pathway. There are no models that really have been shown to work. There's nothing that's scalable and sustainable. It's highly dependent on the Medicare Innovation Center, which could be at risk, but I think, so again, keep your eye on that. Medicare's plan coming into the season has been to aggressively develop new models, and of course, because they're all new and experimental, they're risky. So think carefully about getting into those. And then, of course, I think the second pathway is going to be your fallback position always, and no matter what you're doing in the first pathway, if you do anything in the first pathway, keep that second as a backup alternative, because whatever you choose in the first might not work, and it could be, that's more likely to be trashed by the current administration, or the coming administration, not in place yet. Remember that we have 1.3 million providers eligible for PQRS and in the first 2 years of MIPS MACRA, only 750,000. And they're cutting off everyone in the right side, and that are likely to come back at the discretion of the Secretary of Health and Human Services, likely to come back in year 3 or 4. But it's only the list on the left that is applicable in year 1, and there is now a low volume threshold, and about 30% of practices that are otherwise eligible for MIPS MACRA will fall out based on the low volume threshold. Excuse me, I said practices. It has actually providers that fall out with 30% of providers fall out with a low volume threshold. Many of you are going to have the choice. If you submit as an individual, or if you're analyzing as an individual, you'll fit the low volume threshold. If you combine yourself in your practice might exceed the low volume. So that'll be part of your strategy. If you lose, you'll want to consider yourself an individual and take advantage of the low volume threshold. If you'll get an incentive as a group, you'll submit as a group. You don't, so you exceed that low volume threshold. And that volume is actually a 2-year measure, but we won't get into that. But there is some complexity to that determination period. And I think the biggest thing that changes from PQRS and meaningful use and quality tiering, that combination of programs into this one combined program, this graph put out by Medicare shows the two things. One is that composite performance score, that it brings all those scores together into one measure. And instead of pass-fail in the old systems, there's a sliding scale, that there's a continuous variable that composite score is used to connect to an almost unique adjustment factor for each level. So this graph demonstrates those two dramatic improvements, I think, from the old programs to the new. I'm delighted we're there. Now, of course, that composite performance score is governed in this way, and it's got a scheduled change for 4 years till it reaches its mature, actually 3 years to reach its mature level of 30 points going to quality, 30 points going to cost, 25 to ACI, and 15, the ACI is advancing care information, and 15 to clinical practice improvement activities. And of course, for the first year, no points to cost and 60 points going to quality. And to blow that out a moment, just to take a, so I have it all written out, and you can have a closer look at that. The new program combines that quality, cost, improvement activity, advancing care information scores into one composite score, and your adjustment factor is gauged to that. And here on the left, bringing in that graph for the adjustment factor is also scheduled to change over 4 years in this fashion, plus or minus 4 in the first year to plus or minus 5, 7, 9, and then it stays at 9. And then an exceptional bonus for the first 5 years is kicked in, and that's demonstrated here in this oval. So in this area, of course, we have the losers, that people getting a negative adjustment. This whole program is revenue neutral by legislation. So when Medicare collects negative adjustments from these people, they distribute it to these people. And dollar by dollar. And then they're also kicking in this extra $500 million to give an exceptional bonus above that kicks in at the 70th percentile. So 30% of practices get into the exceptional bonus range. They're planning to cut off the cross at the 0 point to be at 60%, so at 60th percentile and below. So again, this is a sliding scale. This is you're being graded on the curve. There isn't an absolute value that can guarantee you'll be in one place. It's really how you compare to everyone else. So this is going to be a competitive system. And of course, 2017, you heard the acting administrator Slavitt describe it as pick your pace. In the final rule, they're calling it the 2017, the transition year in iterative learning and development period. And the graph looks this way for that first year, so it's dramatically different. And the pick your pace options are to do nothing, and do nothing is this area right here. If you do nothing, you will lose 4% of your Medicare allowable charges. Every check cut to you in the 2019 payment year will have that 4% taken out of it. Now, if you submit one single measure, you will avoid the penalty. That gives you this score of 3, puts you right in there, and you'll lose nothing. And every little bit above that will push you up the incentive scale. Maximum set. Now, this is not set in concrete. This is Medicare's estimates of how things will work. It really depends on how many people, since this still has the revenue neutrality requirement. The more people who don't participate, the more money there is to distribute here. But because they're making it so easy to get out of the penalty, they think the maximum you might earn from in the first level is up to close to 1%, with another 1.5% kicked in by that exceptional performance bonus. So that's, then there's, again, some data moves you up the scale, little bits at a time. All in really means, for all in, it's just a 90-day reporting requirement in that first year. And then, of course, you can also be an advanced APM. And those are your 5 pick your pace options. And measures, you basically have 2 approaches to submitting a measure. If you submit a measure that has a benchmark, has at least 20 cases, and meets the data completeness criteria, you get full scoring for that. And if you submit in this transition year what they call a Class 2 measure, it's a Class 2 measure if it doesn't have a benchmark, if you don't submit at least 20 cases, and the measure does not meet measure data completeness criteria, which means that there's no mandatory percentage. 1 patient is enough to meet it. 1 measure is enough to meet it. You get 3 points for each measure you submit like that. And that doesn't apply in the web interface or administrative claims. And I don't plan to delve into this, but there's also some redistribution policies. There's ways that you exclude from advancing care information, and you might not have any quality performance category score, and they redistribute the points in these ways if those are the cases. So that's a quick review of the common underlying. Now let's dig into the quality. So the specific rules for quality, it's not going to vary much from what you already know about quality submissions. All the mechanisms and measures and dynamics of that you learned in PQRS are applicable in the MIPS system. Now they've reduced the measure load from 9 to 6, so you only need to submit 6 measures, and you don't even need to submit 6 measures. You remember in PQRS, of course, you remember in PQRS, if you miss 1 measure, your whole submission is thrown out. But in MIPS macro, in MIPS, if you miss a measure, they just adjust your score. So that dynamic is very different. There's a requirement of 1 outcome measure or intermediate outcome, but of course you also you can miss that as well and just not get scored for it and lose a little bit more because of that. They do want if there's no outcomes measure, you can use a high priority measure, which is the only way we're seeing domains now in the new program. There's no requirement to have at least one measure in each of 3 domains, but we do see that domain language coming back in these high priority measures. Not all measures are high priority, not all are sorted into these domains, but measures in these domains can replace that outcome measure. And if there's fewer than 6 measures that apply, you can submit all that apply, and there are some validation tests that are not live in 2017 but will come live in 2018. And in the final rule, they eliminated the requirement for a cross-cutting measure in 2017. I'm not sure that will remain out in future years, but my guess is that it won't come back. We'll see. There were 3 administrative claims quality measures. They're keeping the 30-day hospital readmissions, but they're making it a lot less applicable. It's only going to be applied to group submissions when there's 15 or more providers in the group, and when there's at least 200 hospitalizations attributed to the group. The avoidable admissions on the acute and chronic side have both been eliminated at this point. They could be revived in future years. CAPS for MIPS is still an option. It's no longer required for groups of any size. You have to be a group of at least 2 providers to use it. It counts as 1 measure, and it counts as 1 experience measure, which is important because that means it qualifies for 2 bonus points at being an experience measure. And you still need 5 other measures to flesh out the 6 requirement. And I have a question. Amber asks, is an outcome measure the same thing as the previously named cross-cutting measures? And no, it's not at all. Cross-cutting measures were measures, whether they're process or outcomes or intermediate outcomes measures. Cross-cutting measures applied to a broad variety of patients and providers in our communities. cross-cutting. But outcomes really has to do with not how you provide care or what care is provided, but what the outcome of that care is, or outcome of the visit is. And it can be a disease relief of pain, cure of the disease, recovery from surgery, but it can also be appointment at the right time, satisfied with the care. That is a measure of the outcome. There are intermediate outcomes as well. Those count for the outcomes measures. And I apologize, I don't have a list of those outcome measures for you today. I'll give you a link to where you can start getting a look at that. Data completeness criteria is changing with a year, both a period, what's the required period for reporting, and what percentage of data. Of course, claims is always Medicare Part B. Web interface is only Medicare Part B patients. Qualified registry, we're moving to all payers in the Qualified Clinical Data Registry, and EHR and data submission vendor submissions. The period now, minimum period is 90 days, is as good as a year in the 2017. Of course, web interface is still, you get your list of patients and you report for your experience over the whole year. And they're keeping the data completeness criteria, the reporting rate at 50% for 2017. Of course, you need to submit your full 248 patient set on the web interface measures, and then they plan to go back to a year on the quality measures for 2018. Advanced care information will also go to a year, I think, in 2018. But we'll get to that in the ACI webinar. And they're planning to advance that to 60% in 2018 reporting rate requirement, and we're expecting to get up to 90% in 2019 and beyond. I've got another question from Gary. If we do not have 6 Class 1 measures on our specialty set, are we in effect penalized since we can only earn 3 points per Class 2 measure? Now, actually, if you're reporting from a specialty measure set, that's one excused absence, if you will. If there's only 4 measures in your specialty measure set, you only have to report those 4 measures, and you get scored in those. And I'll show you that scoring in a little bit. But if they present 6 measures in the specialty measure set, and you can only submit 4, you only have data accessible for the 4, then you'll get penal. Then you'll be, your score for those 4 measures you'll submit will be averaged as if they were 6 measures, so it will bring your score down. So there are bonus points available. 2 points if you submit an extra outcome measure or a patient experience measure. 1 point for any other high priority measure that's in your measure set, and bonus points are capped at 10% of the denominator. Whatever that denominator is, your maximum denominator is 70, so your maximum bonus points is 7. But you also have a second class of bonus points, the electronic submission bonus points. If you have an end-to-end electronic submission, that is, you're extracting your data from your EMR, you're passing it on to your vendor, they've got automated systems to process it, and they upload it to Medicare, that's end-to-end electronic. What Medicare wants to avoid is a point that you alter that. The qualifications there are the clinical data must be documented in certified technology. The processing must not include abstraction. That is, you can't go case by case and judge your performance. And there can be no pre-aggregation, so you have to give the raw data to your vendor, not aggregated reports. And all mechanisms are eligible for that other than claims. So you don't have to do an EHR submission. You don't have to be subject to that 63 measure or whatever it is this year, the 63 measure limitation. All measures are open to you because the EHR direct, the data submission vendor, qualified registry, QCDR, web interface, these are all eligible for that electronic end-to-end bonus. Oh, and the bonuses, also one point per measure that has that end-to-end electronic reporting, so you don't have to do all your measures that way. Those that you are able to engineer with an end-to-end electronic flow get that point, and it's also capped at 10%, so a maximum of 7 points to the electronic bonus. So here we're back to the too few measures. Well, missing measures are scored at 0 and averaged in with the rest that are submitted. They did not come live with a MAV, measure applicability validation test, for 2017, but they promised some reformatting of that for 2018. Probably not called a measure applicability validation test, or more a clinical, I can't remember but there's something that's in the works for 2018. It's interesting that they have created these specialty and subspecialty measure sets to protect you from having to go out beyond those. And it's only by using that measure set that you get forgiveness for fewer than 6 measures. But of the, I'm only estimating at this point, I'm guessing there's 20 from my perusal of the sets, 20 specialty and subspecialty measure sets. Only about 2 of them have fewer than 6 measures. So the rest of them, you have to choose from amongst the available measures, and you don't get a pass for not having 6. So only 2 do you get a pass for not having a full 6 measures. And if it's not scored, if you get exempted, then the average is adjusted. The measures you submit are averaged just with themselves, and you don't get a demerit on your scoring. What is the difference between an intermediate outcome, asked Rhonda, intermediate outcome measure and an outcome measure? Do they both count towards an outcome measure? Good question. They both count towards your requirement of having an outcome measure, or either of them do. But from the language, I suspect, and we'll have to see how Medicare operationalizes this, and look perhaps in their policy documents that go beyond the final rule. But the wording I would expect they're going to interpret as meaning only the outcome measures qualify for 2 bonus points. And I would suspect that intermediate outcome do not, and perhaps don't even qualify for even 1 unless they actually hit one of the high priority measures. So an intermediate outcome, if someone presents with a fracture, I should actually, I can't think of any examples in the measure set to give you an understanding of this, but conceptually, you have an event like a fracture, and outcome is recovery. When the incident is all over, it's recovery or failure to recover. That's the ultimate outcome. But there can be intermediate outcomes, like control of pain, or out of surgery successful, or discharge from the hospital. Those are all kind of intermediate before that final outcome. So conceptually, that's what that means. All right, so now that's another big improvement in the new system. If you submitted only 8 measures, or one of your measures was malformatted, or there's a technical problem with submission, for any reason the whole submission under PQRS was invalidated. But under MIPS, that's no longer the case. And here to illustrate how that scoring is different, here are 6 hypothetical measures that we're submitting or required to submit under the new program. Your full load being 6 measures. I'm ignoring for the moment the administrative claims measure. So there's a total possible score, each of these has a possible score of 10. So in my hypothetical case, you're each making, you're earning 6 points out of 10 for each measure. So with a full submission, 36 out of 60 equals a 0.6 score. Oh, excuse me, 60%. Is 60% of your total score. Now, if you just miss those 3 measures and they're not excused, you still have a total possible score of 60, and these total to 18, so your score is 30%, or 0.3. But if they're excused, let's say you submit them, but they have fewer than the 20 required patients, or you have only 4 measures in your specialty measure set, so 2 of them are excused for whatever, you still get this total of 18, but these are excused, so your total possible points is reduced from 60 to 30, and this is a 60% score. So that's the 3 separate scoring scenarios that come from that. No longer required that you have to submit 6 measures. Top-down measures are an issue. Medicare has been thinking about just eliminating them, and then realizing if they did, that a lot of you would still have trouble getting a full measure set since they don't have a good selection of measures for all specialties. So they're keeping top-down measures, which is good news, I think. But they are adjusting. They're going to adjust their scoring down, but not in the first year. So 2017, you do not need to worry about top-down measures. No measures are going to have a reduced scoring because of being topped out. And you don't need to worry about the math in those first couple of bullets. So basically, it's where your percentile rank is going to cluster people together at the top of the. So let's say 50% of providers report a 100% performance rate. That's a top-down measure. In the long run, they plan to reduce the scoring, so you can no longer earn a full 10-point score on a top-down measure. They'll give you the midpoint in the range. So if 50% of submitters submit a 100% performance rate, your top score will be 7.5 for that measure. So it's scored at the median. And that won't be happening until a year after it is identified as topped out, and they're starting fresh with a 2017 performance year, so it won't be until 2018 that any measure can be scored as topped out. And Medicare's done a nice job with this informational website. So this is a good place to start to get your, to explore the specialty measures, to look for outcomes measures, to access their rules as they bring them live. It's relatively sparse at the moment, but I think you can expect it to be fleshed out over the next couple of months fairly aggressively. So take note of that, that website, look there. Look at our site. We're continually going to take their specs and their communications and interpreting them and putting them in fairly simple terms on our site, and continue to have webinars and blogs to help explain these things. Don't hesitate to ask if you have a question, confused, submit a question. We're happy to answer them and answer them for everyone. Risk adjustment at this time is limited to hierarchical condition codes. Say that 3 times real fast. HCC codes, used to see those only in Medicare Advantage plans, but they've been used for risk adjustment in PQRS right along, and that's continued to be used in the MIPS system. Benchmarks, interesting new approach to benchmarks. Of course, benchmarks have always been a normalized score, which is a ratio of your deviation from the average to the standard deviation. That's what happened in MIPS, or excuse me, in PQRS. In MIPS, it's a percentile rank. So as you submit, they'll rank you by score, and then compare that to the percentile and create that sliding scale or that grading curve based on that. So no matter how good you are, 50% of you are going to be below average. This is going to be very competitive, this whole system, and 60% of you are going to fall below, into the penalty range, and 40% are going to fall into the incentive range, and that won't be static. That's going to change every year as people rise to the challenge and improve their metrics, and that's, of course, Medicare's plan. They want to see us get better year by year. So the benchmarks, expect them to be specific to every submission mechanism. So there'll be a benchmark for qualified registry, another for QCDR, another for web interface. Oh, excuse me, web interface is a special. There is a special one for web interface. It's shared with Medicare Shared Savings Plan, and for EHR. There's a 3-point floor for new measures. So you're protected in a new measure. You can never score lower than 3 points. In PQRS, the 2015 data we just submitted this last March is going to be used as the benchmark against which you're judged for 2016. And we haven't seen those benchmarks yet. We're expecting them any minute to be released, so we'll be able to look at your 2016 submissions and tell you how you're going to perform against those benchmarks. In MIPS, they're moving it a year back. So your 2015 benchmarks are going to be used for your 2017 submissions. So those benchmarks that are going to be released soon for us to judge your 2016, of course, that judgment is going to be based on the ratio of your deviation from the average against the standard deviation. They're also going to release that in a percentile rank, and it's the percentiles that we'll be using as benchmarks to compare your 2017 data. They'll still be risk adjusted by the hierarchical condition codes. If you have fewer than 20 eligible instances, it will not be contributing to the benchmark. 0% performance will also not be contributing to the benchmark. And APM data, data from practices that are participating in alternative payment mechanisms, models will also be included in those benchmarks. Now in PQRS, new measures wouldn't be scored until they had benchmarks, but that's changing in MIPS. They'll develop benchmarks on the fly the year that it's introduced, and you will be judged, but you won't have any way of knowing how it's going to be judged. And so using a new measure will be somewhat hazardous, but they are protecting you to some extent by saying the minimum is 3 points for those. So the scoring, let's walk into that. So each measure is scored on a 1 to 10 scale in this new program. A missing measure gets a score of 0 unless it's an excused measure, in which case your number of measures gets dropped, the denominator gets reduced. Measures submitted and valid but not scored are removed from the average. That's an excused, well, that's not really an excused absence because you didn't, it was there. So the reasons they're not scored, again, fewer than 20 patients is the most likely reason that they're not going to be scored. Actually, it must have a benchmark to be scored. Well, I guess that's true, but again, they're promising to develop a benchmark in that year for the new measures, so that should be universally applicable. And when you submit more than 6 measures, they're going to give you credit only for the top 6 scores. So incoming data, when we help you prepare your submission, or your submission is prepared any other way, that comes to Medicare as a percentage score. That is performance rate, 0% to 100%. They're going to change that to a decile rank. Excuse me, I was calling it a percentile rank, but decile rank just moves the decimal point 1 over. So it's a scale of 1 to 10, not 0 to 100. Of course, they're doing it at a precision level of tenths of deciles. So those of you who are mathematically adept who still remember your grade school math, or maybe that's middle school, that turns it into essentially a percentile scale, a 100-point scale. So it's expressed in that. So here's how it looks. There's 10 deciles, and every measure will have its own breakdown of which percentage scores, which performance scores fall into which decile, and that will be determined in the usual way. You just line them up, and then so it's not a mathematical determination. It's a ranking determination. Now, those of you who heard my webinar about the proposed rule, I think I misinterpreted it, but the language is a little vague. So it looked like they were planning to mathematically divide the space within each decile, but it does look like they plan to have a full rank everybody and rank it in order at the 10th of a decile. So this just makes it easier to see. We could just as easily give you a 100-point table here. Now I also wonder about this is exactly out of the rule, and they seem to be lacking the 0.1 to 0.9 area. I wonder if that's intentional or accidental. So this, when they operationalize this, we could get another breakout there. And I think what it would mean is this 10th would run from 9.1 to 10, and the first would 0.1 to 1. So we'll see how that pans out. But again, it is you're going to be ranked, and it's that percentile rank that will judge your scoring. Top-down measures. So here's an example of the chart on the right for the top-down measure. So the first through the 5th deciles break out, but you get to that 6th through 10th decile, and there's 100%. Everyone submits 100% level at that level, and midway between 6 and 10 is 8.5. That's not exactly right. I'm going to have to dig into their examples a little deeper, or just to accept that these are not necessarily accurate. So let's dig into a hypothetical scoring example. 6 measures. So they aren't going to be mistaken for measure 1, which is hemoglobin A1C. I've given these letter distinctions, and there are 6 of them. And of course, there's a single administrative claims measures, which is the readmission measure. So in our hypothetical case, we've submitted an outcomes measure using using an electronic methods, patient experience measure using electronic methods, a process measure using electronic methods, then an outcomes measure without the electronics, a high priority patient safety measure without the electronics, and we missed one. We only submitted 5. So eligible instances are the next column. Everyone has 20 or more measures, so none of them are eliminated because of that lack of low eligible instances. The scoring that we delivered gets translated into this decile rank that's displayed here. Every one of them, every one of the measures has 10 potential points, and because this measure F was not excused, it was missing, it's included in the average. You get 1 electronic bonus point for each of those first 3 measures because they have electronic flow. You get 2 extra points, 2 bonus points for measure B because it's a patient experience measure. You get 2 extra points for measure D because it's an outcomes measure. So here's where we are. So for total, there's 60 points possible. Because you're excused from the readmission measure, that's not possible, so you're not getting that 70 points, but there's 60 possible points. And now multiplying that by 10% is 6, so there's 6 maximum points in each of the bonus categories, and that applies to each of the bonus categories. We actually get scored 41.9 points on our submissions, so that's the total from the 5 submitted measures. There are 5 points in the priority bonus column, and there are 3 points in the CHRT bonus column. So, and they each fall under the 7-point, oh, excuse me, that's a 6-point bonus cap because you only had 60 possible points. And the total score is capped at 100%. So we've a total of 8 bonus points between the two categories. So 41.9 actual points plus 8 bonus points gives us 49.9. There's 60 possible points, so that's the divisor, and it gives us an 83.2% score. The maximum points that we can apply to the composite performance score is 60. So we're looking for 83.2% of those maximum 60 points. That gives us a 49.9 points toward the composite score. Now, I may have lost you there, but that's let's look at it graphically here. So we just determined this number. We've got this quality score of 49.9 of your 60 possible weighted points, which pulls us here. Let's assume you can get your full 25 advancing care information points and your full 15 clinical practice improvement activity points. In our example, that puts you here. So we draw a line, intersects the revenue neutral piece here at about 0.8%, and it hits the exceptional performance bonus here at a combined adjustment factor of 2. So we're estimating that in this case we could get a 2% positive adjustment based on that quality performance. So what does it all mean? It means that performance matters. It's not just a matter of getting a submission in that qualifies. And it really means that you should choose measures that matter. It makes no sense to invest in submitting measures that you don't care about. If your practice doesn't give flu shots, even though you can submit on flu shots, you shouldn't, because you're not going to perform well. And you should invest in performing well if you don't care about flu shots. So adjust those labels for whatever your specialty is. It's going to be very important that you choose measures that matter, and that when you make investments into improving your flow and improving your data, that it's done on things that you want to brag about to your patients and to your referring providers. Come to me because of this. So it should make a difference. Have extra measures in the hopper. If you need to submit 6, work on 9 to 12. So when it comes time to select your measures to submit, you can choose the 6 best and be working. It might take multiple years to pull a measure up to a level where it's competitive nationwide and it's going to deliver top performance for you. It's going to take work over time, which is another reason I suggest you don't take 2017 off, but engage now. So you put your infrastructure in place, you start recognizing your measure performance early, you start working on your documentation. Well, here, the data stream is down in that last set of bullets. The data value stream, you provide the care, but that's not enough. You've got to document the care, and that's not enough. You've got to document the care in a place where you can extract the data. And you have to actually extract the data. It has to be translated properly by whoever's doing the reporting for you, and it all has to meet the submission requirement standards. That's a lot to be done, and again, we could tolerate some level of errors in that stream under PQRS, which was paid for reporting, but errors in that stream in MIPS is going to bring your levels down, and you'll want to work on every one of those to make sure your metrics come to the top. So, we're trying to let everyone pick their own. We talked about it in Secretary Slavitt or Administrator Slavitt brought forth those pick your pace options. We're suggesting a pick your effort option. Now, some of you just don't want to do anything more than submit a data set. You got too much to do, you're a small practice, not a lot of resources. Emphasis is on reporting, you're just going to do the bare minimum. And our goal is to minimize disincentives, minimize the negative adjustment. And it even get you as close to zero adjustment as possible. Some of you just have limited resources, but want to make the best use of that. And our goal is to get you a small positive adjustment, 9 to 12 measures to work on, to submit 6 or more, and principled redesign of your cost structure. Presume you get most of your care information points and improvement activity points. And then if you're all in, there's probably 2 different models for that. The community care model, where you want to maintain some flexibility to be MIPS this year, perhaps an APM for the next 2 years, back to MIPS, things like that. And you probably want to just watch those ACO measures, the 15 measures that are now in the web interface measure set, their equivalents in the qualified registry area. Work on those, and depending on what you need to submit year by year, spin it out in whatever way you need to. And the multi-specialty model, you might not be preparing for that community care type of approach, but I hear a lot of my clients want everyone to have skin in the game. 1 to 6 measures for each specialty, and then choose the best. Have a bunch in the queue to choose from the best when you make your submission. So that's kind of where we're going. We've started to re-engineer our system to rise to the MIPS challenge almost the moment the legislation was signed. We certainly adjusted that when we saw the proposed rule, and adjusted again a month ago when the final rule was published. And we have a fairly aggressive plan to roll those out as you need it, starting really almost immediately. Automated data connections, so it can be hands-off. You don't need automated data connections to earn the all electronic flow data bonus, but I think you want, for continuous access to reporting metrics and early warning of malperforming measures, I think you need that. And that brings us to the second point, that continuous access to performance metrics. We'll be overlaying a BI tool on our system, so you can drill down from enterprise to practice to physician to a patient list for each of the measures, and of course be able to roll up to get different perspectives, so you can get full control of those metrics. And the comparative data, build the benchmarks in, benchmarking our own system. We have an enormous database of data now, 32,000 providers in our database for the 2015 reporting season. It's growing every year. Put that at your disposal through the Muse Collaborative as a learning collaborative to learn with and from your data. Every one of you is going to have strengths that everyone will be able to learn from. Every one of you is going to have weaknesses. You'll be able to learn from the high performers. And we'll deal with all performance categories, whether it's advancing care information, the clinical practice improvement activities, as well as quality, and also deal with cost. Even though we don't have a reporting requirement for cost, we want you to help you excel in that area as well. And flexible outputs. I think we've been camping on the most reliable, and the qualified registry method of reporting is still the most reliable, but it's hard to predict exactly when you might need one of the others to meet one of the APM requirements, or simply because the QCDR construct, and we have a QCDR in place, we're putting more in place for the 2017 year, when special measures might not serve you better. To find those measures that matter to you. So, this is the final slide, really. So we plan to continue those things that we're very good at, being very available, highly affordable, highly effective, be there for you, and build in this new, just expand everything to make sure that you have what you need in the MIPS system. So don't hesitate to raise any other things that you need or say, what about? And we are available for questions now, so feel free to, there we go, briefly go here so you can get, don't hesitate to submit your questions by email if we don't get to them here. So Stacy asks, was that graph showing only a 1% positive incentive for maximum performance in 2017. That's CMS's estimate. Again, they're probably reasonably accurate, but it really depends on how many of you step up to the plate and do anything. And the more that do nothing and contribute and lose 4% by not doing a damn thing, those will add to the pot, so that could rise. But that is only an estimate. It's not going to be determined until the submissions are in for 2017. Excuse me one moment. I'm going to just go to Denise asked, so I don't want to forget Denise's question. She sent these in by email before we started. So we are currently in EMR variant and we'll be switching around April to iKnowMed. We had planned on reporting for the whole year, but with 2 different EMRs now, we are hesitant that info could get lost in the shuffle. What would be your best suggestion? Well, I think I would suggest that you just use one EMR. You have that 90-day requirement, and it looks like each of them will have a 90-day period of time in 2017 that you're live. So you could choose whichever. You're probably more mature in the earlier system in Varian, that may have the best data set, but then again, there's reasons why you're changing. And if those reasons are because it was inadequate to document some things that you want to report on, then iKnow might be the better. Presuming you get live with iKnow, you might not have all your documentation templates built. You might not be getting the data you need for some measures. They might not be populated as well. It depends on how well your data comes over. So I expect your data is not going to be as good in iKnow in the first year. So I would be inclined, again, lots of variables here, so we'd have to really dig into it to give you better guidance. The variant data is probably better. Now, and I talked about the changes from the Washington, the new administration. So there's more questions, but I noticed that we're 1 minute away from the top of the hour, so I wanted to validate that and say some of you have to get some real work done, so you may want to pop off now to get some work done. But we will, as usual, linger here as long as there's questions and answer those questions. And if you submit your questions by email afterwards, we'll get to those. I've also been posting those on the blog, or intending to. They should be getting there shortly, for the benefit of everybody. Okay, so I'm going to start, well, here we go. I think I've got them lined up by the time received. Denise asked, would you recommend CAPS? Not necessarily. CAPS, if you're going to do a survey and you're going to pay and want to do a paper survey, CAPS is a good idea. It's a great idea to survey your environment. I'm not sure that the rules around CAPS make it very efficient. I like lighter weight measurement systems, and in the QCDR we're putting forward this year, we're going to be focusing on a lighter weight survey method. I liked when I was running EMR for a health system, we had implemented a one visit, one patient, one question policy that we always asked a single question, just rotated through the questions that we wanted answered. And through a single day, we typically got a statistically significant sampling of those questions. And being so lightweight and so immediate, people usually answered and didn't ignore as often as when they get a paper or a phone call survey. So yeah, I do recommend surveys. CAPS isn't a bad idea, but there could be easier, cheaper, more immediate ways to do that. Gary asks, if we do not have 6 Class 1 measures, oh, we talked about that one already. We talked about that one. Lori asks, States data completeness of 50%. Is that 50% of all patient data or 50% of Medicare, even though all payers qualify? It's 50% of all payers. They have not backed off on the all payers requirement. So, in essence, your the volume, if you're extracting your data, you're going to have to give us bigger extracts because you have to include all payer data now, not just Medicare. If you're abstracting your charts, it's really going to be a burden because that means a table of practice has about a 30% Medicare load. So it's going to multiply by 3 the number of charts you have, or a little more than 3 the number of charts you'll have to abstract to get a full data set. GP asks, if a provider doesn't hit the 30,000 allowed charges, does he have to apply for the exemption, or will Medicare automatically exempt? Actually, Medicare will be doing that automatically. In fact, they'll be measuring you in advance, and they have 2 measurement years, and if you, the 2 years prior to your performance year, and if you exempt in either year, you're exempt from reporting. So that's interesting. So the year that you report, you could actually have plenty of volume, but because either of the last 2 years you had a low volume, you'll be excused this year. If you're, Sandy asks, if you're a rural health center under the same TIN as additional practices that are not rural health center, if the organization decides to report as a group for the TIN, will they pull data from the rural health center that is exempt due to low volume? The low volume exemption is going to be applied at whatever level you choose to submit. So if you choose to submit or to be evaluated, you don't have to submit if you're low volume. If you choose to be evaluated as an individual, then your low volume would prevent you from having to submit. If you're submitting as a group, they'll judge you as a tax ID number. So it's the higher volume of some of the members that pull the rest in. So by submitting as a group, you'll lose that exemption for the individuals who have low volume. And again, you'll judge that by how you think you're going to perform. And our goal is to give you that data up front so you know whether you're going to be subject to an incentive, and if you'll get an incentive, you'll choose to submit as a group to avoid the low volume threshold. And if you be subject to a penalty, you might choose not to submit as individuals. So those who do have enough volume will do the submissions they have to do, and minimize their loss or even get into the incentive range. So yeah, you'll have to. You'll need data to help make that decision year by year. How many bonus points for Danielle asks, how many bonus points for additional high priority measures, and how many can you report? You can report more than 6 measures. You're only going to be scored on the best 6. I don't think you can get bonus points for anything beyond those 6 measures, with the possible exception of the improvement bonus points, which we haven't talked about. They haven't really defined that yet. The first year you might be able to get improvement bonus points would be the second year, but that's I'm getting off subject. So again, your maximum points are 10% of the total, and your total can't be any more than 70 points. So you're topped out at 7 for either of those categories. I don't know what the top is going to be. Chances are they'll coordinate those, and you might get another maximum of 7 points for improvement bonus when that comes live. So the high priority, the experience measures. High priority, of course, earns 1 point. Patient experience or outcomes measures earns 2 extra points. Again, maximum to 7. Electronic end-to-end electronic flow. Essentially, you can earn 1 point for each of six measures. It's maxed out at 7, but there's no way you can earn 7 points because they're only going to be scored on 6 measures. Let's see. Oh, Danielle asks, can Denise combine data from both EMRs? And the answer is yes. She can combine data from EMRs. It's harder. No reason not to, except, again, we think the newer EMR is not going to be as mature. You're not going to have as good data there. So you have to, but there could be reasons why you just do both. But with that 90-day requirement, you only need 90 days for 2017. It's valid to choose one or the other and save yourself some trouble. But yeah, combining is perfectly valid. Let's see. What? That's it. Okay. I think that means that the last question has been asked, and we're ready to sign off. Oh, I'm still ready to go. All right, okay, I'll pull away. Thank you very much. It's been delightful. You didn't throw anything. You asked great questions. You didn't hold me until it got dark. So there's lots of things to be thankful for today. And we'll see you soon for. Well, I'm not going to tell you which it is because I don't know, and I'm not going to mislead you. But Charles will have sent out the invitations. Talk to you soon. Bye-bye.